Thank you very much. My name is Jim Mulshine. I'd like to welcome you to the second day of the Prevent Cancer Foundation 18th Quantitative Imaging Workshop. We had a wonderful first day yesterday. We started with a very moving award ceremony for Mary Pasquinelli's efforts in leading a screening effort in a federally qualified clinic in west side of Chicago. And it underscored the importance of the efforts of all in initiating this very important but complex process. And so we thank all those people in the front lines helping to make this happen and moving implementation. We move then to very important consideration of incentives and the landscape of population health, which is driving change at many levels in the United States. And Bruce Pyenson led that discussion with some very, very insightful colleagues. We moved from there to a session that was run by David Yankelevitz and Chris Lathan, talking about big data and how it could help inform our activities, refine our activities, optimize our activities going forward. And then Chris helped us with understanding the importance of engagement in the communities that will be undergoing screening care and having their input from the get-go in terms of how this could proceed in a way that would be most impactful across the board. It's very important discussions. We concluded with some breakout discussions, one a technical discussion about imaging features, and that was, as usual, a very animated discussion. I think finally find a path to progress. And then in the second breakout, we're talking about clinical issues with screening and bringing some of the issues that we discussed yesterday forward to figure out what is achievable in terms of the oncoming year. So I'll stop there, and we have a wonderful panel on elements of COPD from clinical to technical imaging. And Javier, you ready to go? Okay, I'm sorry. We're fortunate to have Al Rizzo, Chief Medical Officer of the American Lung Association, our co-sponsor in this workshop this year, to lead off. Thank you, Al.
Thank you, Jim, and good morning to everyone. Welcome to day 2 of this QIW workshop. The overall title of this session, Elucidating the Evolution of Thoracic Disease as the Basis for Rational Clinical Management. As Jim said, I'm currently the Chief Medical Officer of the American Lung Association in the practice of health. I'm pleased the Lung Association is once again a sponsor for this work, not only because the acceleration and adoption of lung cancer screening is part of one of our key imperatives for disease lung cancer, but because we're now exploring how the low-dose CT scan may also be able to help improve the lives of all patients with lung disease, which is another important imperative of lung disease.
Al, sorry to interrupt, but your audio is very poor. I don't know if you're, people are writing in the chat that they can't hear you.
Let's try that again.
That's better.
All right, thank you very much. Sorry for the glitch there at the beginning. So I'll go back. I want to welcome you. And as I said, elucidating the evolution of thoracic disease as the basis for rational clinical management is the topic of this 2-hour session. As Jim mentioned, I am the Chief Medical Officer for the American Lung Association, and for that reason, I'm pleased that the Lung Association is once again sponsoring this workshop, not only because the acceleration and adoption of lung cancer screening is part of our key imperatives to defeat lung cancer, but because we're now exploring how the low-dose CT scan may also be able to help improve the lives of all patients with lung disease, which is another important imperative of our mission. Before presenting the format for the next 2 hours, I want to harken back to the QIW workshop from last year, when we heard from panelists, some of whom will be on today's agenda as well, particularly our moderators, George Washko and Javier Zuleta. The 2 sessions last year were entitled, Can the Low-Dose CT Scan Be Used as a Window to Early Lung Disease? In other words, is there significance in the CT findings on low-dose CT scans related to emphysema, airway changes, fibrosis, etc.? And does that bear reporting in a structured manner by the radiologist? The other session then asked, can we move to the point of intercepting pulmonary disease, or can we make these early changes in lung imaging that are seen on low-dose CT scans, something that we can intervene with and apply to patients that make a clinical difference in the quality of their life, morbidity, and mortality. So today we're going to build on those discussions. As I mentioned, we have our two moderators again from last year. Dr. George Washko is a physician at Brigham and Women's Hospital. He's also an associate professor of medicine at Harvard Medical School. Dr. Washko is a National Institutes of Health funded investigator in COPD, specifically focusing his work on imaging and quantitative image analysis. Other moderators, Dr. Javier Zuleta, who's professor of medicine at the Icahn School of Medicine and chief of the Pulmonary Critical Care and Sleep Medicine Division at Mount Sinai Morningside Hospital in New York. Dr. Zuleta's research interests include lung cancer screening, diagnosis of lung nodules, and the relationship between lung cancer, COPD, and emphysema. We have a number of other experts on our panel. A lot more details can be obtained on their bios in the program. But I want to make sure that this is a discussion that's interactive and free-flowing rather than didactic in nature. So for some structure, we've labeled the first hour as, is annual thoracic screening a venue to deliver preventive interventions? Are there defining gaps in disease evolution? And if so, can we learn from cohort studies of otherwise healthy millennials? As soon to be able to be a landmark study representing this is going to be what Dr. Ravi Callahan will talk about in a pre-taped video that we're going to show shortly. He has described this study as possibly the Framingham study for the lungs or the search for the pulmonary cholesterol. Dr. Callahan is director of the Northwestern Asthma and Chronic Obstructive Pulmonary Disease Program and associate division chief for clinical and translational research in Division of Pulmonary Critical Care. And as I mentioned, he's the lead PI for the NHI-funded and ALA Health Lung Cohort Study. I believe he's scheduled to enroll his first millennial next week, so he can give us much more details on that during this talk. The topic that will be addressed, at least on paper during the second hour, will have to do with building a guidance document for the rational clinical interventions for thoracic screen-identified pre-symptomatic pulmonary disease. In other words, translating the images into clinical interventions, and can we speed the process by which this can benefit patients earlier in the course of their pulmonary disease. I'm going to briefly introduce our other panelists, and then I will turn it over to our moderators. One of the panelists is Dr. Lee Gazorian, Director of Quantitative Analysis and Co-Director of Research at the Leahy Hospital and Medical Center. Primary research interests are to apply quantitative computer tomography imaging technology to lung cancer screening and COPD patient populations. He's returning from last year as well. We also have Dr. David Menino, who's currently the medical director at the COPD Foundation, has a long history of research and engagement in respiratory health. We have from our steering committee, Dr. Raul San Jose Estepar. He's co-director of the Applied Chest Imaging Laboratory at Brigham and Women's Hospital, and associate professor of radiology at Harvard Medical School. His laboratory focuses on novel computational imaging applications for image-based biomarker discovery to empower epidemiologic and genetic studies and provide novel surrogate targets for drug discovery and clinical trial development. And last but not least on our panel, we have Dr. Ruth Tausinger, currently the president and chief scientific officer at the COPD Foundation, and is an internationally recognized and innovative, patient-focused, and highly analytical healthcare leader and clinical scientist with extensive R&D experience. As I mentioned, you can find much more detail in our programs on each of these bios. At the end of the 2 hours, I'm going to sum her up and try to come back to several main takeaway points that we want to address during these 4 hours. One is the important role of longitudinal cohort studies in assessing disease development and progress. The other is, can we define the current interventions, excuse me, that can be implemented when early preclinical disease is recognized on CT scans? Third, can we identify research gaps in developing disease-modifying agents when early lung disease is detected on these scans? And lastly, how can we expedite the recognition of the role and importance of early detection of lung disease by these CT scans so that healthcare providers can be stimulated to use these clinical interventions at the bedside? So now I'm going to turn it over to our moderators. I think they want me to play the video first. Is that correct, George?
Yes.
So we're going to go to Dr. Ravi Callahan's pre-recorded video.
For the opportunity to share some thoughts with you about how we can consider respiratory health and the life course evolution of chronic lung disease in the context of imaging, as well as sort of more broadly as we think about how to conceptualize impaired respiratory health. These are my disclosures, some consulting and research support with some industry partners. I want to take a moment just to talk about how the respiratory community has typically defined health and implicitly then defined disease. Lung health in adults has traditionally been defined as the absence of disease. Early disease then becomes defined as the first appearance of abnormal lung physiology. And that works perhaps finding early disease if we want to test today's therapies. In contrast, I make an argument that thinking about lung health and how to preserve and idealize and promote lung health is critical for disease interception. The trajectory of decline following attainment of peak lung function is variable. But in the respiratory community, we actually only seem to care if it declines into a threshold into the disease range. For example, in FEV1 below 80% of predicted, or an abnormal FEV1 to FVC ratio. And then outside of smoking, there actually are limited data on factors associated with maintenance versus decline in pulmonary function. I'd be remiss if I didn't talk about sort of the historical perspectives on lung function decline, the Fletcher and Peto curves, which ascertain that in susceptible smokers, there's an unrelenting decline in lung function. And if someone quits smoking, there's no way to restore someone to their ideal respiratory health. Of course, this notion that people wake up every day with a little bit less lung function than they had the day before is a conceptual model and probably not true. And perhaps we ought to think differently about how to maintain a straight line across lung function as the life course progresses. This was modified by Burroughs et al., who sort of acknowledged that there's a lower limit of normal and people may not have the same peak lung function in young adulthood, and that there may be episodic declines with restoration to occur in people who experience lung function decline. This, of course, became all the more newsworthy over the past 5 or 6 years, largely informed by this important paper that Peter Lang and Bart Celli and Alvaro Agusti were the co-lead authors on, that combined information from multiple cohorts to really depict that now in the 21st century, there are 2 pathways to COPD. There are people who on the left side have normal lung function at baseline and then have accelerated decline in lung function. But there also are people who start out with abnormal lung function at baseline and have less decline in lung function, but both of these groups had COPD defined by spirometric FEV1 to FVC ratios less than 0.7. Our group actually reported similar data in the Cardia study, whereby we looked at people who had abnormal FEV1 to FVC ratios between the ages of 38 to 50 and what their FEV1 trajectory was across their age ranges. And we really found that people who had obstructive lung physiology between the ages of 38 and 50 had sustained lower lung function from the time they were really early in adulthood, in contrast to those who had no evidence of obstructive lung physiology. What about these trajectories and how they lead to disease? Well, this is work that my friend and colleague George Washko led in the Cardia study, whereby we defined trajectories of lung function in Cardia, which is a fantastic cohort of people recruited between the ages of 18 to 30 in 1985, and now followed 30 to 35 years later. George looked at trajectories of FEV1 decline in Cardia, and we actually came up with this depiction of lung function, whereby there are people with persistently poor lung function, there are people with ideal respiratory health, and there are people who have declining lung function or preserved impaired lung health. We looked at the prevalence of an abnormal FEV1 to FVC ratio in these folks, and we found that people were had abnormal lung function across the spectrum of this in terms of FEV1 over FVC, but the prevalence of abnormal lung function was greatest among those with persistently poor lung health, next highest prevalence among those with worsening lung health, and then people who had this intermediate phenotype of preserved impaired respiratory health and FEV1 that sort of stayed around 90% predicted across their life course actually had a significant proportion of people with obstructive lung physiology. We then looked at people and whether they had abnormal CT scans. In this case, we looked at the visual emphysema and the prevalence of it. We found that people who had both persistently poor lung health, as well as those who had worsening lung health and accelerated decline in lung function, had similar prevalence of emphysema. And again, this intermediate phenotype of preserved impaired lung health had more emphysema than groups who had preserved good lung health or those with ideal respiratory health. There are other ways maybe to phenotype respiratory health. In an analysis of cardia, we actually asked the simple question of what if people have respiratory symptoms between the ages of 25 to 27, and would that portend risk of future chronic lung disease? And it turned out that people who had symptoms between the ages of 25 and 27, if those symptoms included cough or phlegm, wheeze, or chest illnesses, had greater odds of future obstructive impairment. And in the case of cough and phlegm, as well as recurrent episodes of bronchitis, it predicted future emphysema on CT scans. In contrast, reporting shortness of breath between the ages of 25 and 27 was associated with the development later in life, 25 to 30 years later, of restrictive physiologic impairments. We don't really know, though, what's going on in the lungs of these people who report symptoms. And perhaps that's, in my view, where the opportunity for utilizing novel imaging techniques could really emerge. One imaging technique that we've become really keen on is the local histogram technique, which has been developed by George Washko and Raul San Jose in their state-of-the-art imaging group. And we've endeavored to put forth the notion that you could use this to create a lung health map. So their characterization technique can characterize areas of lung across a variety of features. And I just want to call attention to one feature, the normal high attenuation feature, which we actually now have termed lung injury. Information from Raul and George's group has put forth this notion that we can use this feature to look at a variety of things. This feature is associated with some increase in biomarkers, ICAM1 and C-reactive protein in both COPD gene as well as in cardia, are both increased in people who have greater burden of lung injury on their CT scan. And it's important to note that we have reported that both CRP and ICAM1 are associated with future lung disease, both future interstitial lung disease, as well as emphysema. In addition, lung injury is associated with future structural lung disease, both central lobular emphysema over 10 years in cardia. The burden of lung injury is associated with a significantly increased odds of the development of emphysema, as well as interstitial abnormalities several years later. What about the intersection of biomarkers and CT lung injury? Well, this is really interesting, that only those people who had a higher burden of CT lung injury did the biomarkers I just told you about predict future structural lung abnormalities. So in those people with CRP and high ICAM1, those who had a high burden of CT lung injury had a much greater odds of developing interstitial features 10 years later. So it's been said that we'll never find biomarkers in the blood of future lung disease because it's too much, it's nonspecific in this and that. But what if we ask the question about whether we could integrate blood biomarkers with a CT-based risk factor that depicted early lung injury and really define an at-risk group for future lung disease, and then view that as an opportunity area to actually test therapies that can intercept impaired respiratory health and prevent progression to chronic lung disease. I'll just wrap up and share our paradigm of lifetime respiratory health. And it really hovers around this intermediate phenotype, that there are people who have susceptibility to future lung disease. It could be due to actual susceptibility to lung injury. It could be due to impaired reserve. But to focus on disease interception we need to think about these two yellow lines, the intermediate phenotypes, and how we can actually intercept them before they descend towards a disease threshold. So some concluding thoughts to maybe inform the discussion going forward. Ideal lung health is more than the absence of lung disease, and impaired respiratory health is associated with a number of adverse health consequences. I didn't even mention all of them, but that intermediate phenotype of impaired respiratory health, where people have decrements in lung function that are not below a threshold of abnormal and may have CT abnormalities in addition, are associated with a number of adverse health consequences. Not only respiratory symptoms, but also impaired cognition later in life, high risk of cardiovascular events, and on and on and on. And disease-focused studies of people who already have lung disease, even when they include people with early disease, don't inform lung health or prevention strategies, nor do they enable interception strategies. Preservation of respiratory health is not solely predicated on avoidance of cigarette smoking. We think intermediate phenotypes of impaired respiratory health can be driven by a number of things, including environmental exposures and other things like respiratory infections, which are extremely timely right now, or other injurious stimuli. And I would argue that major gains in cardiovascular disease prevention are attributable to health promotion, and that the absence of disease-agnostic respiratory health studies in the US have hindered our efforts at prevention. We don't have the cholesterol of the lung, and actually integrating imaging biomarkers with traditional blood biomarkers present a clear opportunity. In a shameless pitch, I'll just point out that we are now recruiting a cohort of 25 to 35-year-olds across the country through the ALA, deemed the ALA Lung Health Cohort, where we actually are trying to collect the requisite information to ask some of these questions. These participants, age 25 to 35, will all get CT scans. We will get detailed environmental and behavioral exposure information on them, as well as health histories, and really try to define their respiratory health and follow them forward so we can think about whether this paradigm of biomarker discovery in conjunction with lung injury is an opportunity for us to answer these questions. That's all I have. Thanks for the opportunity.
Thank you very much. What a wonderful talk and a great introduction to the next discussion. I want to remind everybody that you can ask questions through the chat, and I see that right now there aren't any questions. So I'm gonna ask one. I'm gonna start with one, and we'll go over to the panel later on. Dr. Calhoun, thank you so much again. I was very interested in your comments about the different subtypes of emphysema. Today, when we see radiology reports and lung cancer screening, we just hear about emphysema without particular specifics. And there's data out there showing that some types, central lobular emphysema, is associated with an increased risk of lung cancer, whereas paraseptal emphysema is probably not. And you showed some data, but maybe you can talk a little more about it. How these different subtypes or phenotypes of emphysema are correlated with long-term lung injury as you're looking at.
Yeah, thanks, Javier. That's an interesting question. It is true that at least in the Cardia study, central lobular emphysema and paraseptal emphysema have similar prevalence in that population of early middle-aged adults. And I think we don't really know what the downstream consequences of that is, of the distribution of emphysema or the emphysema subtype. We also don't know what the upstream trigger is. It's a really good question as to whether, there are two ways to get to emphysema. There's the person who has poor peak respiratory health, and then there's the person with accelerated decline in respiratory health. So that's the paradigm we've set up. And I don't know that we know the answer as to whether paraseptal versus central lobular versus other emphysema subtypes are different between those two trajectories. We certainly didn't look at that in specific in our analysis, although it's a really good question. I think this other notion about the normal high attenuation area, or what we're calling CT lung injury, whether that's a precursor of disparate future phenotypes is also unknown. We're doing that work now. We're collecting more CT scans and cardia to try to understand that. But, you know, people have CT lung injury, and it's tempting to believe they could either go towards pulmonary fibrosis and interstitial lung disease, or they could go towards emphysema, whether it's paraseptal or central lobular. And some of them could sort of have lung cancer as well as a consequence of this injurious stimulus. And why people go in one direction or the other is not known. It could be due to the upstream exposure as risk factors. That may not be relevant at the time you obtain CT imaging anymore. But I wonder, I'm really keen on this notion of whether biomarkers, blood biomarkers, can inform different future pathways in the context of people who have that CT lung injury. So our approach is to do blood discovery proteomics, right? We're doing blood proteomics in all these people to try to see whether the proteomic signature at the time someone has a burden of CT lung injury actually predicts a divergence towards different phenotypes over the next 10 to 20 years.
Okay, great.
So,
George, do you want to add any comments to this?
yeah, maybe I can jump in. A quick question. So thank you, Robbie. That was a great talk. The one thing you mentioned at the very end, which resonates right now, and you're talking about future development of extrapulmonary manifestations, right? We always think of COPD as this multi-morbid syndrome. Are you suggesting that the canary in all of this process, the thing predicting how our body falls apart, is actually lung dysfunction or impaired lung health? Because that's very interesting, and I think would also get into some things that maybe Lee Gazorian would cover as he's thinking about the holistic utilization of imaging around respiratory and whole body health at Leahy.
Yeah, well, thanks, George. I'm not of the mind that someone develops lung disease and then everything falls apart. I'm of the mind that everything is falling apart together, if you will. I mean, falling apart is not the right term, but everything is emerging as an impaired health phenotype at the same time. And I think that's true. And we always use lung as the predictor because we're a respiratory epidemiology research group. So we center everything on the lung. You could do it the other way around too. But whenever we look at these intermediate lung phenotypes, they're associated with everything bad. Lower lung function is associated with future cognitive impairment in papers we've written in cardia. It's associated with brain MR changes. It's associated with future risk of cardiovascular events. Most of them are heart failure events, but heart failure is the prevailing event causing thing these days. It's associated with functional impairment, right? Inability to do things on a day-to-day basis. It's associated with every adverse health factor when someone has this intermediate impaired health phenotype, which to me really implies sort of the shared evolution of impaired health status that encompasses impaired respiratory health. Now, the problem, I think, is that when we've studied this previously, we've usually done it in the context of a disease study. We've done it in ECLIPSE, or we've done it in COPD gene, or we've done it in, spiromics is mostly people who have obstructive physiology. And if you only study people who have the disease, well, then it's really tempting to say the disease is the risk factor. But I would hazard to say that someone with an FEV1 of 90% predicted is worse off across their entire complement of health factors than someone who has an FEV1 of 110% predicted.
Okay. No, this is that's interesting because even sort of, Rick, as we were thinking about the technical session last night and the needs, and I know that Javier is going to touch more on this of the extrapulmonary things, I think this also bolsters the discussion of standardization of the precision and the reproducibility of the metrics we extract from these CT scans.
So we have a question here by Mary Pasquinelli. Are there different patterns of phenotypes by gender, sex, or race?
Yeah, that's a great question. We have we've recently started to look at this in the context of race and sex groups, and we haven't come up with a consistent set of findings, except that the burden, at least in Cardia is an interesting sample to study race in because it was recruited in 1985 as a population that is half Black and half white deliberately, and then balanced by socioeconomic status as well in an old-fashioned sampling strategy, you know, population-based sampling. So it's as unbiased as can be. In Cardia, the prevalence of emphysema among Black participants is much, much higher than among white participants, and particularly among Black men in Cardia, where at year 25, so mean age 50, the prevalence of visual emphysema is 15 to 16%. It's really, really high burden. It's higher in Black women than white women, but the difference is not quite as high. It's something like 8 versus 4%. But Black participants are at much higher risk of emphysema in Cardia. And it's likely due to exposures. There's not, you know, I should say out loud, right? Race is a social construct. I don't think there's something innately at risk in Black participants than white participants. But the behaviors and risk factors in the United States in terms of socioeconomic disadvantage, smoking, and other exposures are probably greater burden in Black participants than white participants. The interesting thing, and we have this paper in front of a high-profile journal right now, and usually when I'm an author on a paper in front of a high-profile journal, that means it'll get rejected immediately, but maybe this will be the one that gets through. But we have a paper that really documents that because of race-based correction of spirometry in the United States, most of these Black participants with emphysema would have normal lung function. Normal lung function, because we correct upward for Black people in the United States. It's a problematic thing to do. But I say that because the CT scan then becomes the detection tool for disease, because those people who probably smoked cigarettes and have other risk factors that would justify CT scanning, now accessing the CT scan in populations across the United States is disparate for sure. But those people's tool to diagnose disease is the CT scan, because if they do a lung function test, the way we treat lung function in the United States now, which needs to change, but who knows when that'll happen, their lung function is going to get called normal. Immense amounts of emphysema, they're at risk for future disease. It really is informative of health disparity in the United States and around respiratory disease, but it also magnifies how the CT scan is the better tool than the breathing test.
So Robin, maybe if I can follow up on that, as you're balancing the complexity of race and socioeconomic status, how is that going to influence your strategy for enrollment in the lung health cohort?
Yeah, so, you know, in the lung health cohort, as you know, George is one of the co-PIs of it. The strategy is to balance enrollment by socioeconomic status, not by race. We think the prevailing risk factors of impaired respiratory health and future lung disease in the United States revolve around SES. And we have a deliberate strategy to enroll half men and half women, and then 1/3 with a below high school education, 1/3 with sort of a between high school and college education, sort of vocational, junior college type stuff, and then 1/3 with a greater than college education to get a representative sample. The LHC, though, I guess it's important to note as well, is really focused on internal validity. It's really focused on things like, is this proteomic signature reflective of what we think it is in the risk of future lung disease? Is it really the CT param findings, whether it's PRM or the high attenuation injury marker feature, whether those are associated with future disease? It's not an attempt to do an actual population sample. That said, our stratification variable is SES as best we can.
Can I ask a question to both of you, to George and Ravi? What parameters or what factors are you looking at to determine or to come up with that lung injury index that you're describing?
Yeah, that's a George and Raul question. I'm gonna.
I thought so.
Should we push that over to Raul?
It's about time he did something.
Is Raul there? Yeah.
Yeah, no, I'm here. Well, I think it's a very interesting question because we are pushing, I think, the limits there of CT, from a technology perspective. I think from a research perspective, that param of lung health, I think it, as you were asking, it has, I think, multiple aspects. It has, components that are extrapulmonary, probably, and I think there is a lot of work in body composition as an interesting modulator. There is components that are definitely lung specific, and it's some of the data that Ravi showed in his presentation, looking at where we consider, inflamed lung parenchyma, that indeed is probably not the best terminology, but parenchymal that we consider normal, but by reference, if you compare against a normal population, is off the mean, it's off the mean by X sigma. So those are definitely indications that there could be some disease activity pre-disease, if you will, that is what is potentially driving these lung health indexes. I guess here, basically what I feel we are sort of against is that obviously there is more than ever all these technicalities around device calibration, having a proper what is normal and what is not normal, not having that kind of epidemiology or a large population data gets even more important. And it's where probably we need to keep discussing and bringing the groups together, from the technical end and from the cutting edge epi research that Ravi is doing, and obviously linking with Lee, what Lee is doing from the implementation standpoint.
To expand on the question a bit, is it something that I, as a pulmonologist, for instance, looking at a CT scan, can come up with, looking at different issues, or is it something that I'll have to press the button and get a number, and that'll give me the lung injury index? Now I like to look at CTs and I see emphysema, and I can, I have a sense of what the patient has. But is this lung injury index going to be something that I can look at, or is it just going to be a number that I'm going to get in the report?
Well, that is a very interesting question, because I think, like everything with perception, and interpretation, I guess I could argue we could all be trained or fooled into seeing something. And obviously, I'm not saying that what we are reporting is not real. Definitely seeing the signal. Clearly, I think we're talking about subtle changes that might be more difficult to qualify visually with current technology. But let's not forget that I think we are also moving towards higher resolution. There is, photon counting technologies around the corner, maybe in 5 to 10 years for a city. So, and I think that will probably expand our ability to somehow interrogate even visually the sudden changes or subtle changes. I mean, I guess if you ask me now, probably it's kind of difficult for a plain human reader, to ascertain this sort of subtle inflamed status, as we call it. But I want to add as well, and will be an exercise to do that. Probably you can pick up if you're tuning yourself for that, you can pick up in other manifestations that might indicate or might give you sort of an indication of, okay, I think this is an inflamed subject. Now that is a question to you. If probably you can, if that was the question that we were posing to you as a clinician, I'm sure you will be able to look at different components that are part of this inflamed phenotype.
Raul, in my dreams as a lung doctor, right, I love looking at the CT scan. Don't get me wrong, I think it's great. But I'm also annoyed all the time that we don't have sort of the cardiac ejection fraction, right? The number someone can anchor on. And if there was a way for the machine to read the burden of lung injury in an at-risk individual, I think that would be pretty flippin' amazing. And people could anchor on a quantitative feature. I mean, it's amazing how everyone knows the cardiac ejection fraction and lives their life according to it. And it's amazing how no one knows their lung function. But then again, I would argue knowing your lung function is not that useful, really. But if you knew the burden of injury, that would be pretty cool.
No, you have a good point. I guess one explanation would be that obviously 4 chambers versus 5 lobes is a much trickier, it's a much trickier proposition. So this is why still we need more work. No, I know where you are coming from, but also what you are describing, I think to me is also digs deeper into the question of link between structure and function. That is a link that we know is there, but still we are slowly uncovering. And have we done all that sort of uncovering? I don't think so. And a little bit the proof is, latest data coming from these sort of AI games. Nobody has been able to predict lung function from a CT scan. Predict, meaning with perfect reproducibility, if you will. So, and I don't know if that is where you are heading. I think we are still lacking, I think, that a little bit some of those links, and therefore probably it's driven because we know all the, we don't know all the structural components leading to either good respiratory health or bad. And I guess that is the premise of lung health. As a study.
Well, part of the premise too, though, and I'm sort of curious what Menino thinks, because he influenced our thinking about this for many years, but part of it is if we hold up lung function as the gold standard, that seems reverse to me. Like that doesn't seem, we have better technology now than to say we need to validate a CT finding against the pulmonary function. That we need to validate a CT finding against the risk of future disease or current impairment across the portfolio of health consequences. To anchor it on the FVC or FEV1 to me seems semi-ridiculous.
Let me invite David Menino to join since he asked a question on the chat and he's been mentioned. Go ahead, please, David.
Yeah, thanks. And Ravi's sort of been channeling my thoughts the entire way. Yeah, I agree. And the technology, as I've often said, for the lung function test is 170 years old. And the FEV1 was or the FVC was developed in the 1850s, and the FEV1 is more modern. It's only about 100 years old. But if we were diagnosing heart disease based on 100-year-old technology and having that as our gold standard, and we would not be where we're at today. And I think that is one of the challenges. And we had the technology and the maneuver of doing a lung function test is something that is not reproduced in real life other than on your birthday when you're blowing out birthday candles. And when else do you take a full inhalation and blast it out as fast as you can? And it's not. And I think sort of you're getting beyond that. And I think we in the pulmonary community have been guilty of many things. We sort of focus on this, and then it has created this circular firing squad about these sort of precise definitions. Well, is this restricted or is this obstructed at a lower limit of normal, and all this nonsense. And it's sort of like, how many angels can fit on the head of a pin, as opposed to identifying people with lung disease who are at risk for developing complications, because of that lung disease in the future. So yeah, and I'd sort of posted a question. Well, does imaging, how close does imaging get us there? Because I think there are advantages to imaging, at least at our place. We get results from a CT scan, and it's like, and they'll measure the size of the nodules and might sort of call out, well, the person has some emphysema, but there's no values in there, and there's nothing to really anchor it by. And when we've seen, and we've seen issues related to imaging, for example, in the RAPID trial that looked at alpha-1 replacement, and it was so dependent on the depth of inhalation and other metrics that although I think the data were compelling, that when that was sort of brought up in front of the FDA as a means of as another metric other than lung function to evaluate therapy, it sort of got laughed out of there. So I couldn't agree more with things that that Ravi has said, and I think going forward, we need new metrics. It may or may not be imaging. My challenge with imaging is that right now it's really not a good. It's not accessible. It's sort of not a point of service thing, and I think and we may be able to overcome that. But if we're going to get to the cholesterol for the lung, and we may need to move beyond this, or this may be as good as we get. I don't know what Ravi thinks about that.
So there's a question posted following on what David just said from Vince Tejasaputra from the American Lung Association. I hope I didn't say your name too incorrectly. What are the considerations for impaired ventilatory efficiency, VE over VCO2, the ventilatory equivalence during exercise, to predict? Apparently, there's some work showing that is more sensitive or closely tied to mortality in the future than spirometry. What do you think about these kind of measures? As you're saying that maybe it's not only imaging, it should be other parameters that we should look at.
Yeah. Actually, I agree with that too. And I know people are starting to look at this, and in theory, an exercise-based thing that could be done in a physician's office that maybe with rapid sort of pulse ox sampling and some statistical gymnastics and other things where one then could get a measure of how the lungs are doing in a real world situation, as opposed to the sort of like the artificial situation of measuring the DLCO or spirometry, and something that would actually be usable, to people. I think there would be great value there, because I think and that's sort of the holy grail we're going at, getting at this metric of what is early disease, prior to a person showing up in our clinic with an FEV1 of a liter. And we've all had them, So how do we find that person 30 years ago? And I think that is the challenge that we're trying to unwrap here.
Okay, so George and I are discussing in the background here a little bit about the how to continue with this panel. We had a plan to have maybe two parts, and after Ravi's talk, have this questions and answer, and then maybe introduce the second part. But the discussion is already opening up in a very interesting way. So, George suggests, and I agree, maybe we should open the panel to everybody on the panel and start the discussions. We had prepared a couple of slides that we might be able to show little bit later, but and I think the discussion is open, and we should continue it because it's very, very interesting. And I'll start with a question from David Yankelevich, who says, that a measure of lung injury is of obvious value, but what do we currently know about the measure? How often does it progress? Is it repeatable? Does it resolve completely? Obviously, these are the key questions that we have to ask.
Well, I can speak a little bit to some of the kind of technical pieces of how reputable it is. Do we know about the progression? So I guess the answer is we don't know yet. I mean, this is sort of a little bit of, as I was saying before, a little bit pushing the boundaries of CT scanning. And I think in a good way, what we want to do is why we also are very keen as a group and as a community on defining better quality standards, on really having sort of the proper steps so CT can become this basically highly precise quantitative tool. But I guess these sort of indexes that come from the kind of the research enterprise are preface a little bit on this sort of high quality, highly controlled, and very with the sort of guardrails around some of the noise considerations that will make these sort of indexes reproducible. So the answer to your question is we don't know that yet. I mean, we know that, when you go from cohort to cohort, and after you do the proper calibration, that needs to be said, we can reproduce the results. But this doesn't mean that obviously there is sort of this quote unquote calibration step that has to be, is key in this sort of quantification. The same that it is for emphysema is that probably in emphysema we have already done enough work to know where the variability is and obviously what we have to do to control that variability. And that is probably some of the missions of the Kiva profile around densitometry. I guess this is on the same track, is the beauty. I think we come from the same sort of basic science and body of knowledge, but it's pushing things even further.
But Raul, that is a key focus. I'll just mention in the current cycle of the cardio lung study, right, is to actually answer the question for people who had CT lung injury 10 years ago, what happens over 10 years, right? And we can actually test the validity of the finding at least, right? In the construct validity of the finding. In that context, does it resolve? Does the same area that has CT lung injury 10 years later now have interstitial lung abnormalities? Does it have emphysema? Is that actually a conceptual thing, or are we just sort of making the whole thing up, which I guess is also possible. But the thing that I find compelling about CT lung injury, right, is that it actually can operate on a continuum. It's not sort of thresholded necessarily. It falls under this notion that 55 is worse than 40, is worse than 10, is worse than 0. And I think thresholds in the respiratory community have been our nemesis as far as health promotion. I really believe that we are a threshold obsessed field, and it causes us huge problems.
Absolutely. And I think, stepping back, and there's also this tension around what is the aspirational measure. And I think lung injury is that. David, to answer your question, conceptually, it's very appealing. I think Raul is correct in dealing with the challenges and maybe papering over some of the challenges that he's solving and going through to enable this. But we don't have a good track record in the community of even having more conventional things. And maybe what we do is we could pivot over to Ruth and who's been leading a lot of the charge through the biomarker qualification panel and looking at densitometry and sort of living the experience for both drug development and now sort of patient care.
Thank you. So I think I have a few slides, but basically the comment is really this is a call to action to invest in assessment of doing lung imaging in earlier disease, because as you said, Ravi, the cohorts that are available are usually in older individuals, and a lot of the data that we have are with people with established disease. So I don't know if we can share my slides, but I thought it would be an opportunity to share how we confront the challenge of developing medicines that are targeting lung structure or any disease that is assessed by lung imaging, and that we need regulators to start working with us, or really to continue working with us, and overall to invest in development of biomarkers or drug development tool across chronic lung diseases, not just COPD. So on the next slide is describing the CBQC that many people here on the call are involved in, but it's a chronic lung disease biomarker and clinical outcome assessment qualification consortium. Originally, we started in COPD, but realized that all the issues that we're facing are faced by individuals working with alpha-1 antitrypsin deficiency or other cystic fibrosis or other lung diseases. So it's a collaborative public-private partnership that is really trying to get the regulatory acceptance or qualification of biomarkers and clinical outcome assessments for CT. We call it biomarker. And we just had a patient listening session, brought a lot of stakeholders as well as patients to give a testimonial on why we need to assess more than lung function, death, and exacerbations in a variety of chronic lung conditions. So we followed it up with an event to legislators. As George said, we're really trying to advocate for innovation in the regulatory space. So if we go to the next slide, please. So on the right top panel are all the efforts, all the biomarkers that we were looking at. And what I highlight on the right here, we had two successes, the St. George Respiratory Questionnaire and plasma fibrinogen. SGRQ has been around for many, many years, well, over 30 years. And look how long it took us to get regulators to say it's okay. This was done with a letter from Congress to really push the agency to qualify the SGRQ, which is used in multiple lung diseases. Constant work rate exercise is still work in progress, still relevant to multiple lung conditions. But I wanted to show that working with a lot of people on this call, we were looking at lung imaging and we were looking at CT scan data and talked at length for many, many years trying to figure out what it is that we're going to try to qualify. So on the left is where we ended up submitting to the FDA a letter of intent for volume adjusted lung density at the 15th percentile CT histogram. A lot of the data that we used were from, from Eclipse as well as COPD gene. This is consistent with data observed in Sporomics. So in a lot of cohort studies showing the association of this biomarker with progression of disease and with mortality. So trying to show that this biomarker is relevant and could be used in the context of use in a clinical trial or in a clinical setting as a quantitative biomarker to monitor the progression of emphysema severity. Could be used in clinical trials, but really touching on the discussion we just had, the whole point is showing the relevance of lung imaging as an outcome measure well beyond other measures that are not as predictive. Following this meeting with the FDA, on the right is that we had a follow-up meeting trying to get people to prioritize what's important to them, and the participants at the session from pharma, patients, others, basically 80% of them said that lung imaging is something that we should push forward. So I think given the discussion and the points that Ravi was making around blood biomarkers as well as lung imaging biomarkers that are aspirational, this is where we are with emphysema, which has been around, measures of emphysema, which has been around for very long. We have looked at the QIW methodology. We used approved FDA software to define the parameter that we were proposing, but we're pretty much stuck, I would say, with this letter of intent, working for years on trying to qualify it. And I think it's pretty much my last slide. The next one is that FDA did get back to us with some interest in what we were proposing, that we shouldn't really talk about lung imaging for COPD, that we should talk about lung imaging for chronic lung diseases. And I think it touches on the discussion that we just had around the relevance of looking at lung structure and in addition to other parameters. So I'll stop here.
I'm very happy that you mentioned, thank you very much, by the way, Dr. Thoracic. I'm very happy that you mentioned other lung diseases, because since yesterday, we're talking about COPD, and COPD. And we're seeing lung cancer screening. Every time we look at a CT scan, we see a host of other issues: bronchiectasis, large pulmonary arteries, early interstitial lung disease, mucoid impaction, tree and bud signs that might suggest an infection or bronchiolitis. I mean, things that really we know that they're not normal. And we're not, radiologists actually are reporting on these, but not in a structured way, perhaps, and not maybe standardized. And there are actionable. We have things to do even early on. So I think we have to, I agree with you completely. We have to expand the view to include all of these processes. And maybe this is a good opportunity to invite Lee Gazorian to talk about CT characteristics, and since he's working very hard on this over at the Leahy Clinic.
No, thank you. I think that's really the biggest point, is these findings are on the CTs. We know that. But the real issue is we're not getting the patients to us, to the pulmonologist. And the thing that really strikes me the most is I've actually been reviewing these charts myself, building a retrospective database outside of lung cancer screening. And just an anecdote, one patient, 35-year-old smoker, comes in for a CTPA for chest pain. It's negative. 4 years later, I'm reviewing her CT scan, which had moderate upper lobe emphysema and never referred to pulmonary, still smoking today. This is the patient that we're going to see who's on oxygen at age 50. And so, when we look at our data from Leahy, I was really fortunate that our group scored every lung cancer screening scan for emphysema as mild, moderate, marked. They did the same thing for coronary calcium. And again, what we're finding is, half the patients are still smoking. 70% of the patients with emphysema have never had PFTs. Our patients with interstitial lung abnormality findings, we actually scored a subset of our patients for ILA and UIP. And of the 10 patients who had ATS guideline UIP, 0 were reported as UIP features by our radiologists. Every single one had interstitial changes documented, but those patients aren't coming to pulmonologists. And so what we're going to do at Leahy is starting in January, we're going to have a lung health clinic. We have an advanced practitioner, and we're going to be using, just to start, just natural language processing, mining all our clinical reports for emphysema, mining all our clinical reports for interstitial lung changes. And we also want to do this for coronary calcium, and identifying these high-risk patients and offering a lung health clinic appointment. We're going to work with our PCPs closely to try to intervene on disease early. One other thing that I remember from fellowship is our chief was giving a talk on COPD, and he mentioned the billions of dollars that are spent every year on the treatment and research for COPD. And a postdoc fellow from Ireland raises his hand and goes, "Why don't we spend that money on smoking cessation?" Right? And he didn't have an answer. And I think these diseases are treatable, and simple interventions like smoking cessation is something we can do to really prevent that woman from going from emphysema to having advanced disease 10, 15 years from now.
So Lee, what I think, this, what you're mentioning nicely dovetails to conversations we were even having yesterday of, the tension. We've had this conversation before of it can be measured, so we should measure it, but then what does it mean anything clinically? What do you do with it, right? So the sort of the chicken, the egg, like, well, just because we can measure a bunch of stuff doesn't mean we're doing anything, we can do anything with it. And so what's exciting is that you could actually be showing the way to operationalize the more advanced assessment of the clinically acquired data to power patient care, right? And I know you're doing a stepwise fashion, but then ultimately the goal is the holistic digestion of the image, all of these things, a multidisciplinary team that's then fed data from a report. And so this, and from improved patient care right down to sort of the cost structure. So, we've learned also that centers are interested in patient care, but also they balance books. And so, one of the other things you're going to be wrestling with is what is the fiscal impact of this clinic?
Absolutely. And there's a huge role for quantitative. For one, I can just sort of say, for BLVR, patients are getting the scans, and as a pulmonologist, we can't look at a scan and say, yes, that's 90% fissure integrity, or that patient has, 50% right upper lobe emphysema by 910, 920. We just can't do that with our eyes. And so that's the role for the quantitative, is to say, all right, these patients may benefit from advanced therapies. The other role is, within our scans, our radiologists, like I said, scored coronary calcium as mild, moderate, and marked. But 3% of the scans, we actually measured Angston scores on these patients. 3% of the scans that have Angston scores greater than 400, there was no comment on coronary calcium. So we're humans, radiologists are reading these, and sometimes when you're looking for nodules, you just forget to comment on the coronary calcium. So I think it's a synergistic role for the radiologists, that having this automatic quantification can sort of help guide, say, hey, this patient might be a BLVR candidate. This one has early interstitial changes that have progressed from last year. This one really should go in to see pulmonary. I think it's a real opportunity to use these scans at a population level, not just screening scans, all of our scans, to identify early disease and get them to the right providers.
Yeah, I see a comment. Maybe Mary, you could jump in and tell people a little bit more about your experience.
So yes, this is Mary Pasquinelli from Chicago. And one of the things that I have realized in the screening program and nodule clinic is the scan is incredibly important to talk about their lung health. In pulling up that scan, and I have very low health literate patients, and just briefly kind of saying, this is, you're laying on the table, left lung, right lung, this is your windpipe. They totally get it. And they say, I feel fine, my lungs are fine, I don't feel short of breath. And when I show them that this is emphysema, this is the nodules, it is a big aha moment. And I have had many patients change their behavior because of seeing that scan. It is incredibly important.
That's clinic also.
Yeah, sorry, Lee, I didn't mean to interrupt.
I'm sorry. No, that's going to be part of our clinic, is showing the scans and actually having a report that goes to the patient, showing them the issue that we want to address in the clinic.
Yep.
Yes, my experience is the same. There's a lot of literature looking at the teachable moment of lung cancer screening, whether it increases the rate of smoking cessation or not. In my experience, and it's anecdotal, I'll just second what Mary just said. I mean, when you show a patient and show them that little bit of emphysema that they have, and you explain what that means and how that increases their risk of lung cancer, I can bet, just by my experience, that is a significant impact on that patient's behavior. So I think that is important. All right, David, do you want to comment, please, on an important aspect? And I'm asking you in particular because of what you have just published recently on that pro-con debate, whether we should screen for COPD or not. And in particular, we're not, since we're not actually actively screening for COPD, and when we do lung cancer screening, We're just taking the advantage of the opportunity, maybe, and we're detecting COPD. But can you expand a little bit on that your ideas about, obviously we don't have actionable or we don't have a treatment for early disease in COPD, and that's why perhaps we should not be screening actively. But does that change it? Do you think it changes when you think about lung cancer screening as an opportunity to detect early disease?
Well, that's certainly possible, and the concept, there that if you sort of carefully read what I had written in that chest commentary, it was basically that using spirometry to screen for COPD is not going to change things dramatically, because by the time a person develops lung function impairment, they pretty much have well-established disease, and we need to sort of figure out a way to move things back earlier. And yeah, imaging may get us there. Actually, I was just curious as to how many CT scans of the chest are done in the U.S. annually. And the number surprised me. It was actually between 75 and 80 million, which is more than I thought it was going to be. Although I suspect many of those are, each person probably has at least two, or at least based on what I see in my clinic. So I'm not sure how many individuals that actually works out to. But yeah, I think to get us to where we need to be, and we would need to get more data that is actually gives us quantifiable numbers. Because right now, the CT scans that I get, it just sort of, and you get a generic reading, and you might get a number for a nodule. It's like, oh, it's 6 millimeter. That gives you something, but I've never gotten a quantitative number on the degree of emphysema in my clinic. I'm not sure whether that's just our local custom here, or a lot of whether the reading algorithms are proprietary. Nothing that we ever sort of see in these research papers ever seems to appear in any clinical reading that I get.
Ravi, do you want to expand on your comment there, which I thought was very good?
Sure. I just said, spirometry, and here I am, a lung doctor, just bagging on spirometry continuously, but the spirometry and screening for COPD via spirometry is like saying we're going to find colon cancer by looking for liver metastasis, right? By the time it's low, we've missed the boat to intercept, which is why imaging and integrative measures of function or other things are just so compelling, I think, in the chronic lung disease space, because everything we've always done is just not very good. It's really, and whether it's in the context of a CT screening study, there is some argument, Raul, to think about how to apply techniques that we use in the cohort studies to a large number of screening CTs and link it to patient-centered outcomes, and just try to understand what the pragmatic implication of the findings are. And perhaps that's something we should figure out how to do, and really see whether we can anchor CT findings on patient-centered measures, whether it's a 6-minute walk or a functional measure of something else, or general quality of life, or sort of the broad portfolio of health indicators. But to do it in that pragmatic context, disconnected from a cohort study, is probably a really worthwhile exercise. But the notion that spirometry is going to help us is just, I think the ship has sailed.
No, I like your point on the pragmatic aspect. I think I like it very much, because a little bit of the disconnect, by listening, obviously me witnessing, from the fences, is that obviously the reality is we are scanning people by the, USP, yes, have guidelines from 50 to 80, I think by the revised guidelines. And obviously this is way downstream to the things, the concepts, the very interesting concepts we are discussing here. And then obviously I see a clear opportunity, as Merit put it in using CT in a more qualitative fashion than quantitative, although we are basically very interested in the quantitative aspects and what it means from the research opportunity, from the drug discovery perspective, or eventually to qualify a biomarker that has some sort of clinical utility. Maybe what we are missing in between is the opportunity to use more qualitative based analysis that now, and you know, I hate buzzwords, but AI definitely what has shown us that it can do very well is this sort of qualitative assessment of data. No, I mean, it's one of the biggest, you know, newsworthy applications of AI has been in just very plain vanilla visual recognition tasks that, although being plain vanilla until very recently were not kind of something that machines could do very well. Now they can, or at least it's shown to be almost at human capacity or human capability. So I wonder if, you know, an interesting way for the field to move forward is people like me, quantitative guys like me, thinking a little bit more about the qualitative implications, no, and how techniques can be repurposed to do this patient engagement, not to do this kind of use of the imaging data, distillation of the imaging data in different ways. Obviously, we always have the opportunity of going upstream as much as we can, but is lung cancer screening going to be that platform? Just for the same thing you just said, Ravi. No, I mean, we will be always looking for liver mets, no, because we are already in that stage.
Well, I think the challenge is that, so if the uptake of lung cancer screening was high in 50 to 60-year-olds, which it's not, but if it was, that age range is sort of the tipping point towards chronic lung disease, right? So I think in that zone of middle age, there's a clear opportunity to understand sort of what the range of phenotypes is, what their patient-centered implication is, and then an opportunity to see how they change over time in a clinical setting, which is link it with EHR like Ruth just alluded to. I mean, that's a really wonderful notion to use clinical databases to answer a clinical epidemiologic question of importance. It's just that LCS uptake, in my perception, in that earlier time point, 50 to 6, well, it just got approved down to 50, but 55 to 65 even, isn't very high. It's probably improving though. I mean, the crowd here is smarter about that than I am, but I think
yeah, the reporting is not, Leah, I think alluded to that, is the reporting of LCA is not standardized. So it's really making sure that we capture more than nodules or suspected lesions, because a lot of the reports of those screens did not include information on other abnormalities.
Yeah, Rob, this is Al. If I could jump in, I think we're starting to touch on what I think from the Lung Association standpoint, and really from a patient standpoint is, you know, we can keep looking for the holy grail, the cholesterol, the imaging, but in the meantime, several people on this call have already said that we see enough on these scans now that make a difference in what a patient understands about their condition, makes a difference about what they want to do therapeutically, whether it's increase their activity on a daily basis, stop smoking, lose some weight. We're just not getting professional societies like ACR, ATS, primary care societies to make the physicians do what they're supposed to do with information that is right in front of their eyes. I mean, we're getting this on a regular basis. And I think from an advocacy standpoint, we need to get the groups like the ATS, like ALA, COPD Foundation, to make a difference for primary care physicians as well as pulmonologists and radiologists, report these things in a way that make a difference. This workshop has been looking at this for a couple of years now, and I think we want to come away with some tangible things to do aside from the research that's going on. I know you're doing all this, and this is great, but we need to have some actionable items that advocacy may be able to help us educate the physicians a little bit more about what has to be said. So I'll stop there. I'll give my piece from ALA soapbox perspective and just see what you all think about how we can do that a little bit better.
No, I think, and then I see Ella has a question, but maybe I'll quickly jump you know, as a general medical person, I would say I can be critical of our group in saying that we're probably being too academic, and we every year we convene, we talk, and then we share thoughts, and then we leave, and we're not being surgical enough in our approach of doing. And so I think we have to make a roadmap and actually carry forward on that. And because there's a lot of great ideas, I'm concerned that the ideas like what Rahul was saying about the more subjective, the objectively powered subjective analysis, which is kind of a cool concept. We should do that. The data are there, and we need to make that roadmap, and that should come out of this workshop. So maybe I'll over to you.
Yeah, so I just had a quick comment. I am a huge believer in quantitative imaging and integrating it into daily workflows. And I think we're going to talk about more of this at the 11 o'clock session as to why. So without going why apples, why not the uptake? But fundamentally, if you don't prove the value to the people who are either want the information or provide the information, it's not going to get provided. There's many, many obstacles to that. Show radiologists the evidence that picking up mild or minimal central lobular emphysema changes treatment and changes patient outcome. Where's that evidence? How do you get it and show it? If you have that information, is it in professional society guidelines to say early detection of those things matter and should be recorded and should be reported? That kind of information is really lacking to drive radiology practices to do it. So there's a bit of a chicken and egg here. There's tons of informational content there. We can visibly see it, we can quantify it, but there are also many obstacles to getting it done. And proving the value, proving that it changes outcomes isn't really there to be able to make the case to day-to-day practitioners to invest in tools, software, IT resources to make these things possible. This stuff is not as push button as everybody would like to think it is. AI, computer-aided diagnosis, they are not widespread clinically available tools in radiology practices today. We are so very early on, but you got to prove the value. You don't prove the value, nobody's going to integrate it. And nobody's going to drive forward, for example, with payment codes to make it feasible for practices to invest. But I don't want to jump in too much on the next session.
Thank you, Ella. And to follow on that line of thought, are we, I'm asking the panel, maybe just so that we can start establishing that roadmap that George was talking about, which I think is key. And that's actually was our task when this panel was convened. Are we at a stage where we can start writing or writing recommendations for standard ways of reporting, for instance, those additional findings, the interstitial lung disease, et cetera? Are we at that stage? Can we start establishing that roadmap to even put it in practice, because there are some actionable findings, or to establish ways of going forward in terms of research in a more standardized way? What do you think? Lee, you seem to be already doing this, and so do you?
Yeah, no, I have thoughts. Absolutely. I get a little hesitant when we say we want the radiologist to report, and every report see pulmonologist. So in a way, how we're going to do it is we're going to sort of centralize it, where our navigator gets a list of every patient, for instance, that has ILA features on the scans, anyone that has moderate marked calcium, anyone that's got emphysema, and we're going to mine those charts and say, all right, hey, this person has mild emphysema, has never seen a pulmonologist, never had PFTs, they're still smoking. We really want to prioritize getting them into clinic. I'll give you another example, the coronary calcium. I started reviewing charts. I took patients who had marked coronary calcium, which equals an Angst score of 400 or higher, and had an LDL greater than 130. And of the 25 charts I just finished reviewing yesterday, only one was on the correct dose statin. 11 of them weren't even on statins. And the number needed to treat there to prevent mortality is not that high. You're talking 30 to 40 people. So I think there's an enormous opportunity to do this in a centralized manner. And I'm trying to think through how we're going to integrate this with our radiology team, because like I said, we don't want to say consult everybody, but we do want to take out the highest risk. And I think that's where the retrospective work really comes into play, to say, what are the thresholds that are associated with the highest risk for adverse outcomes? And maybe those are the patients, that 5% that we say, refer them to the lung health clinic.
But does it make sense to write, for instance, some guidelines or some recommendations or some asks to the radiologists, please inform these, report on these issues in the standard way, and we have to figure out what that is.
So our group is great. They already do report emphysema as mild, moderate, marked. They already report coronary calcium as mild, moderate, marked, but our ILA reporting is not great. If you look at our scans and the reports, we quantified ILA and we scored it manually in about 1,700 patients with 600 longitudinal scans. If we just use the clinical findings from the reports of subpleural reticulation, fibrosis, we'll catch 90% of the UIP cases, but we'll only catch 75% of the patients with ILA by the Fleshner guidelines. But, so I'm working with our radiologist just to standardize the reporting of interstitial lung changes. Richard Thomas is our thoracic section chief in radiology, and he's going to work to build a macro for just the reporting of interstitial lung abnormalities. But it was difficult getting our group even to score UIP. So I think just having the ILA yes, no as a feature, and then we as pulmonologists in a centralized way can identify this is the person we want to come into the clinic. For the person who's already seeing one of us, is already getting PFTs, they don't really need to come in and be seen because they're being managed by our group already. But there's a large percentage of patients who have these findings who it's not till 5 years later when they're symptomatic, their FVC is 50%, that now we're finally seeing them.
Before we continue, just a comment that Liz Hall is asking us to please, and when you send comments to the chat, open it up to the entire, to everyone, so that people in the audience can also participate in this amazing discussion.
So maybe if I can follow on, Lee, with what you're saying and then pivot back to maybe the point Ella made. You are generating, I think, and in the position to generate a lot of good observational data in the retrospective part of looking at the misdiagnoses, the missed opportunities, and then you'll have an additional prospective part as you power up your lung health interception clinic. Question, I guess, back to Ella is, what is the level of data that radiologists needs to see to believe that it's useful, right? I mean, and maybe that could even be broken down by feature. So we know emphysema is obviously maybe one of the hardest things to intercept in terms of therapeutic development and sort of intervention, but all the other things that are going on in the lung have, to a degree, therapies, right? And so, what case do we need to make to have these things reported? I think you're on mute.
Oh, sorry. Providing information in a way that proves the value proposition. So is there a white paper on incidentally detected thoracic abnormalities and its impact on health that a group of major professional organizations could work to produce to provide guidance about why these things matter? Right? That doesn't exist. There's no place I can point to radiologists that says, well, I can do it for a coronary calcium score. There's a consensus paper from the SCCT and the STR. I got that information. I can make that case. I don't have something that pulls all the information together for the radiology community about why you should report anything else. Bone mineral density, sarcopenia, emphysema, interstitial lung abnormality, that packages it together that says chest CT is a vehicle for public health and lung health. And these are the things you can be detecting, and these are the reasons why, and this is the difference it makes. That information hasn't been packaged together in a way that is usable and tangible.
Great point. So maybe a question to the larger panel: Are we the group to do it, or who do we need to engage if we're not?
I mean, on that point, the Fleischner Society has been trying to do a little bit of that. Maybe I agree with you, Ella, that maybe we don't have all the evidence coming from the research community to then kind of more the implementation community, if you will. No, but I think there is groups like that, and definitely I think Fleischner will be very happy in intersecting on these topics. Will probably are the right groups to do it in one hand, and on the other hand, there are already public statements out there and white papers describing the implications and speaking to the radiologists, specifically for the ILAs that was published a year ago in the Lancet Respiratory Medicine. So I think the evidence around the importance of reporting these findings, I think is slowly being there. I guess probably the little bit of the gap, and it speaks to the essence of this workshop, is then the quantitative reporting of this. And I think I find we debate ourselves between, I can see it, like Javier was saying, I can see this, or how can I see this versus how can I measure this? And what is the meaning of measuring emphysema? And I think that is where we have a bigger struggle. But to me, it's very clear, or there is enough compelling evidence that reporting emphysema has a clear implication on your future risk of lung cancer, for example. So I wonder, I think is great we are having this discussion. The question will be to channel these through groups that are already thinking about this and doing this kind of activities or driving these guidelines.
So let me just respond to that a little bit, which is, the Fleischner Society is a great organization. It's small, and most people think of it as related to lung. They don't really think of it as an organization that is all things quantitative related to the chest. I really think in organizations like ATS, ACCP, bringing together organizations of that caliber has major influence on the practice of medicine. And even if it's a white paper where it goes through where the evidence exists and where the evidence doesn't exist and where we need to go, that kind of a white paper would be really impactful. I like the Fleischner work on ILA, but the practical reality that I get from radiologists is we always see a little dependent atelectasis. People come in short of breath into ED, there's always dependent atelectasis. They don't feel comfortable calling ILAs in real clinical practice unless you've got a really good, pristine, great inspiratory CT. So, translation from what could be and how you actually do it also needs to be taken into account. But I think if we get major organizations together on the caliber of ATS, ACCP, to begin to create a consensus paper on where this exists and where it needs to go, what the quality of the evidence is, I think will make a big impact.
But we also need to target the education to the clinicians, because the thing is, even if the radiologists do buy into this, there has to be something in general practice as well as the pulmonologists that actually learns to appreciate that and to refer patients to pulmonologists, because in most cases, the data will be there. It will go to primary care doctors or nurse practitioners, but then not go beyond that. So I think it's something that we need to target education beyond radiologists or pulmonologists.
This is where I see the benefit of a centralized system. Instead of educating all the primary cares on how to act on this, what they're reporting, if you have a centralized system that can take that quantitative imaging or qualitative reports, build a list of patients who are at risk, and then do the outreach.
Right.
Yeah, you need
I also think you have to be careful to think about how medicine is practiced, and it's practiced in different ways in different places. But in the US, primary care pretty much owns the screening business. Patients come for basic health, for basic screening through primary care. So I think whether it's centralized or decentralized, primary care needs to also be engaged and consider it part of their routine practice as well.
But I'm actually not talking about screening. I'm talking about any incidental identified on any chest imaging. So it doesn't have to be screening. The vast majority of scans are not screening scans. At our institution, we do about 20,000 scans a year, of which only 3,000 are screening. So there's a large percentage of scans that are non-screening that are picking these diseases up that are not being acted on.
But the quantitative component is important. As you said, we need to define what are the thresholds that a primary care clinician would see that as a flag to action, to do something about it. So standardizing the methodology and standardizing what is normal and what is abnormal, it has to be defined there.
Yeah, I'd like to build on that comment because this is about screening. And screening is going to be, well, it's been endorsed by the U.S. Preventive Services Task Force for the extended indication that people have mentioned. That's 14, 15 million people. The rate of lung cancer screening uptake actually is doubling year by year. It's on an exponential ascent. And the value of lung cancer screening is that it's annual, it's paid for. Now, we have some challenges there for sure, but your ability to extract information from a CT scan when you have 2 scans over time is profoundly more important to clinically aggressive stuff than a one-time thing in an ER or whatever. And the ER, we don't know what the risk profile of those people are. We know the people with 2-pack years of tobacco exposure amongst the highest risk individuals in America. And it contains 50% of the premature mortality in our entire society. All the other things in medicine combined, over the next 26 things combined, does not equal the mortality impact of tobacco. And so you have a unique opportunity, and you have some vanguard populations at Leahy, in ILCAP, in the VA, and stuff like that, where you can prioritize some things. Potentially, it's been discussed that anything that you find on CT scan in the context of a continued smoker presents an incredible opportunity for more coaching, more cessation tools and stuff like that. There's been discussion about thresholds for referral to pulmonologists and stuff like that. There are some things that you can prioritize. This is complicated. We did not include coronary calcium in discussion this year because we recognized that this was complicated and we needed to go forward. The cardiologists have already taken these kind of new findings, and it's not the big guys. It was small professional societies that said, hey, let's take a few things, create a construct, throw it out, throw it up the stairs, see what lands. And then the American College of Cardiology and the others this year, last year actually, took those guidelines that were proposed, and they're not guidelines, they're guidance that were proposed, and they built them into their cholesterol and statin recommendations type program. So you're a vanguard in terms of screening and quantitation. And you're thinking, the people on this panel, the people in this audience are thinking more about this than any other group, and I include Kiva in this group, by the way. And so if you make some proposals, and you don't have to say, you can put all the caveats at the beginning, you will catalyze the input of the other groups, the chest societies and others, and you'll get them engaged because there's so many other things out there that are distracting them, that you could start this process by just saying, okay, we got some examples, we got some test cases. The vanguard groups at Leahy and ILCAP and others are going to work together on these on a regular basis. And we're going to start some diagnoses or conditions that we think are worth mentioning, and then some potential interventions that we think are important. And we heard about things like activity yesterday that in almost anything you mentioned would be beneficial. So there's some material that you guys could just start and do it very humbly and get this process moving in a way that, independent of this group, may not happen for quite some time.
David, you want to say something? David,
Well,
sorry, David.
I'm kind of going along with what Jim said. You know, I remember years ago many years ago, we started reporting coronary calcium before anyone else was sort of routinely reporting it on screening. People were saying, "Why are you doing this?" You know, and now it's happened. You know, Harvey Heck got involved. He wrote the initial guidelines. He was working with us, and I kind of don't understand why the pulmonary community is so timid about setting guidelines. I mean, you know, we 25% of people don't even know they have emphysema. X% of that have severe emphysema, never even had a pulmonary function study. To me, it doesn't seem difficult that we should be making some basic guidelines. You have severe emphysema, you know, see a pulmonologist or get pulmonary. I mean, you know, we could do lots of things like that right now. Yeah, Claudia is here with me. She's saying we already do it. I mean, we make some of these kind of recommendations. We do things for, you know, various things. We started within our institution. We get buy-in from, you know, whatever the department is, whether it's the breast cancer service or the liver hepatologist. And we made guidelines, you know, for different findings. And, you know, but for lung, to me, this is obvious. You're sitting with the chief medical officer of the ALA in this group. You know, I think this is you guys are the right ones that are thinking about this. You know, there was, I'm trying to remember when it came out, but a few years ago in radiology, they were looking at this and they had an editorial, 2011, Leon editorial by Furman, where he said radiologists really need to step up now and realize that we have to change the way we do things. You know, we need to, you know, there are things that are quantifiable and we should now take that position of reporting these things. I think, you know, to Ella's point, while I agree fundamentally that, you know, you need to have a clinical benefit, I think that we can quantify a lot of things that we already know are important. And I think we need to lead, you know, in terms of doing it, and it will come. You know, I really do think that. I think there are several things that we can measure now that are very important. And if I don't give this microphone to Claudia, she's going to jump through the screen. So let me do that.
Yeah, I mean, can you hear me? We have a structured report that we've been using all along that at least details that you have small airways disease, how much emphysema you have, how many other findings there are in the lung. It's pretty straightforward to fill in. And we should put that data, we can put that data together and with the quantitative measures and with the pulmonologist all together, come up with recommendations in a fairly quick time.
I think we just, the pulmonologists are just being a little too timid these days. I think that's, you know, you got to look to your cardiology colleagues. But I do, you know, all joking aside, there are things that you guys do. You always understate that there are interventions, you know, and like you said, smoking cessation, pneumovax, you know, exercise, and knowing that you have, you know, emphysema, just knowing people have it is going to make a big difference.
David, since you and Ella are joining us here, there's a question by Mary Pasquinelli, who I think is very interesting to maybe hear about. Radiologists seem to be reluctant to recommend referrals to specialists. Is that an issue here? And
I think yeah, I saw that comment and I agree with Mary. And you know, radiology referrals are very practice level specific. If you live in a closed health system, it's easier to make decisions about, you know, you see ILA, you see early unexpected pulmonary fibrosis, you see mildly severe emphysema, it's easier to make that recommendation for referral to pulmonary medicine. If you live in a purely outpatient ambulatory world where your practice is dependent on referrals from different medical practitioners, they may take offense if you start to make recommendations to specialists. They may think they've got that covered. They may already have a specialist in those areas. So it's really one of those practice level sensitivities that I think does really exist. And so, you know, while it's one thing to get over, okay, you make the findings, you describe it, you quantify it, and get all that buy-in, I think practice patterns and referrals really are an important thing to consider.
But that's
Well, but
probably
the
where,
guy-
I'm sorry,
was
that's
gonna
probably
say
where Lee's centralized system might play a role. And you avoid having to refer directly, but just having a reach out from the centralized system.
Yeah, and again, it gets to practice patterns. So, I live in a centralized health system where, 95% of our patients are seen within our system. And if there is information to go back out to the referring physicians outside, it comes back through our specialists to those primary care physicians. We could do that. We could put in one of these AI tools, pick up coronary calcium and emphysema, and have a work list that's monitored and work with our cardiovascular medicine team. But we would be going through our population health program here to institute something like that. So it would become a system level program. When you live in a decentralized world, again, it's challenging. So then you'd have to identify a radiology practice that says, yeah, I think this is important for population health. And they would have to be working with their referral network to make sure they understand what they're doing, because it can be taken as a double-edged sword of information and recommendations.
So you should, but that doesn't preclude you from doing it within your system or any of the other systems. I mean, point is there could be some recommendations, and however we decide, at least make sure you have pulmonary function studies or whatever, certain things. It doesn't necessarily have to,
Well, maybe we should just start from just go step by step and start by just making, recommendations on how to report in a standardized way without having to, recommend a referral or whatever. Just, how to report on emphysema, how to report on ILD, et cetera, to come up. And following Ella's idea, let's look at the evidence and let's write it up and say, hey, there's evidence that if you find ILD and on CT scan, that might be significant, and we can recommend on how to report on it. That's it, without having to recommend referrals or other stuff.
I don't agree, Javier. I think you guys know more than that. You're holding back. The cardiologists give very specific. If you're in this category, you should consider statins. If you're in this category, you should be, whatever.
But no,
I think you can do that here, at least
we can.
broadly.
What I'm saying is that the radiologist doesn't have to do that. What I'm saying is the radiologist doesn't have to tell the primary care physician, you should send your patient to see the pulmonologist. Just recommend on the report on the findings, and then the pulmonologist should get involved in however way we can to do what we know how to do. I agree with you.
Yeah.
I think I would stay away from the who, and I would just say the what. These are the epidemiology should be reported. This is how it should be structured and quantified. And these are the next management steps. Just stay away from who does the management steps, because that's really practice referral issues.
Yeah. And one thing, Javier, in the current reality of screening, there is a very prominent role for the Mary Pesquinellis of the world. And I think advanced practice nursing is going to be the one having these conversations with a very significant fraction of the screen community. And I think they're much more fluid on moving forward and actioning these kinds of informations and actions. And I think it's great to celebrate the possible. And so I think that whatever recommendations we do and we vet along the lines of what Ella's talking about, we should also engage with the advanced practice nurse community and others, health professionals that might be in this dialogue that can be helping us advance this kind of approach.
I fully agree with those last two comments. Ella and Jim, I agree that a management, what should be done, and not who should be doing it, and engaging, particularly realizing that the nurse practitioners are going to be more and more involved in this, and would love to, I think, well, Mary should comment. I mean, that to me is a critical aspect of this. I agree, especially with all the other findings we're going to be making and can comment on.
Yeah, I can comment as far as the screening program goes. So I run the nodule clinic and the lung cancer screening clinic, and I work in thoracic oncology too. But it really depends on what system your hospital has. If you're looking at primary care PCP nurse practitioners, they may be just like the primary care doctors where you're doing a visit in 15 minutes dealing with a lot of other issues. But when you have a centralized lung screening program where that nurse practitioner, most of them are ran by nurse practitioners, and I love that, where that nurse practitioner has 20 or 30 minutes to review that scan, look at everything, talk about the coronary artery calcification, talk about the emphysema, talk about smoking cessation, talk about risk reduction. That is where you're going to get the big benefit. Having that one-on-one and using that the scan as a teachable moment. And we do it for our lung nodules clinic and our lung cancer screening clinic. It's just how people are going to develop their lung screening clinics. Super important.
I think you're really onto it there, because one of the real challenges with it is we have all this wonderful information, and the private physicians don't have the time. I think what you're doing is just the right way to do it, to show that scan, to go over, have guidelines that are really focused and can give people, I think that would be fantastic. I think that's the,
And then
that's the way
I would add to it, I think we should create patient-centered reports with the information, which is another way of getting the information in the hands of the people that it most affects. We did a trial of using a personalized output from lung cancer screening CTs that was aimed at looking at its impact on smoking cessation. And we looked at their lung health, their emphysema, we looked at their coronary calcium score, their cardiovascular disease risk. And if they were to do X with respect to smoking cessation, this could be the impact on their life expectancy. So you can package information graphically in a meaningful way directly back to patients. That is not hard to do if you build an algorithmic report. And I think it's another audience that needs to take ownership and get the information in a way that is impactful to them.
This is 21st century medicine. This is what the U.S. Preventive Services Task Force is strongly endorsing. And if we can give them a use case where this actually works, and this is a spectacular use case, I think we help our cause, our patients, and the health of the nation. It's great.
Also, I want to point out that it also depends on your institution and the buy-in with this. I had to, after I got up to past 1,000 patients, our program quickly ramped up. I couldn't handle it all by myself. And I showed the upper administration the data, the importance, the vision of doing this. And they were able to hire another nurse practitioner who takes the lead on helping me see every patient for lung screening. Well, most patients, some primary care doctors only wanted to do it. They wanted to order the scan and follow the scan. So it's a little bit of a hybrid, but most of the patients are now coming through our centralized program where they met with the nurse practitioner. They do, the smoking cessation, look at the scans, review it, and then it's a closed loop that we order the next scan. And our return to clinic for our annual low dose CTs, for our lung reds 3s and 4s, it's now at 100%. So showing data is super important to administration, and looking at the cost of having that nurse practitioner, it covers the cost. And we're able to show the administration that it is cost effective and it's improving outcomes.
This is Al again. Can I jump in? I know it's getting close to 11 o'clock, but I wanted to mention a couple actionable items, and I'm going to enlist all of you who have commented on this call. We are going to produce a white paper from this discussion. Hope to be able to circulate it among all the panelists and certainly some of the people who have jumped in. And we are going to use that to go to places like ATS, ACR, primary care societies as a first step. The other thing that we're doing very shortly in the next few months is updating the ATS and ALA implementation guide for lung cancer screening. We did this about 3 years ago. It certainly needs updating because of the new recommendations, but I think an important part of that will be putting into that how different institutions are doing things such as reporting actionable items and maybe recommending some of the things coming out of this workshop this morning. So I'm going to offer that as 2 actionable items that ALA is going to help move forward. We're going to need people like the COPD Foundation, ACCP to help along with us. So look forward to getting some edits from you after we get this white paper put together. And yeah, this discussion has gone full circle from very scientific, academic, what we need to measure, how we need to measure it, to hopefully some actionable items as well. So, and as always, I thank Javier and George for moderating this. Well, I don't want to close it out now. I know we have a few minutes, but I wanted to at least enlist your help going forward. George, Javier, any other comments?
No, I mean, I think that's great with the white paper. I like a position statement, but I also think we need to have something more action driven. Again, taking David's critique to heart about maybe we are being too pedestrian or too academic in our approach, and we're not the doers. And so I think there should be a triage list of what we do and the deliverables, and it may be feature specific. And you know, how to translate that into practice will take some discussion. But I actually think we should do something. Right.
We're here to help out.
Great.
Any other comments from the panel or anybody else? I think this was a fascinating discussion, and thanks, Al, for those action points. I think we should also, you know, agree that we all agree that we should write that white paper. We have to come up with a white paper. So I would encourage the leadership of this organization to set the stage for that.
I just want to thank all the panelists as well for putting this together, taking the time, these couple hours this morning. So I think we're just a few minutes early from our break, but we will adjourn until come back to it. 11:15 is the next session. So thank you all. We'll talk to you in a little bit.
Thank you.
Thank you, everyone.